and I will take you in the order and we'll get you a microphone. We already have a question down here.
Yeah, I'm going to. So one thing I noticed about the program today is I don't really see anyone coming with a gender studies perspective here. It's mostly just about medical, medical fields. But we do have a gender studies department here in University of Copenhagen in Denmark, for example. There are plenty in Sweden and Netherlands. And some places you might even be lucky to have queer studies or a trans studies department. So, well, I don't see these knowledges or these fields integrated very much in the Danish system. Unfortunately, I also see a lot of biodeterminism going again in the kind of language used in the presentations here today. But I'm wondering, maybe, if not someone from Netherlands or Sweden, at least TGEU or the UK might know someone who has experience with, sorry for that, someone who has experiences with that integrating knowledge of gender studies in your work. This is a question to everybody on the panel.
Okay. Oh, is it still? Yeah, I think perhaps we can have somebody come to turn the sound. So, Peggy or Stefan?
Should we maybe collect them?
What?
Should we collect some questions and then?
Do you want to do that, or we just take it now? If there's anyone, no, I think we'll just take one at a time at the moment.
The key point in your question, could you just concentrate on that? So since I don't get too wide in terms of gender studies, we have multitudes of gender studies.
I'm thinking specifically on gender studies having to do with the idea of constructed gender and how this plays together with the rest of society and discrimination against transgender people. Especially, I wonder why I see someone working in this field still calling transgender boys as girls or talking about natal gender, when gender studies has a lot of theories suggesting that things are not as simple.
I don't know if you want to comment on that.
Well, I already said in the beginning that the whole issue of terminology is a symposium on its own, I guess. And that's why I just wanted to be clear about what I was referring to. Sometimes if you want to have the correct terms, the terms become very long and it's sort of hard to pronounce it every time. But I know the EPAT and the EPAS, I think as well, recently made a document where all the sort of correct terms for all these different concepts are described. So there is, I think, a lot of discussion on terminology, but we came a long way. I mean, we are both in the field for many decades, and you see that every decade terms change and the way of thinking about phenomena changes. But sometimes it probably slips under our, how do you say that? Yeah, we are trying to say the right words, but it's sometimes difficult to think of that. It doesn't mean that we do not think that what is discussed in gender studies is unimportant, but that's much more on a theoretical level than on a very practical day-to-day level. I mean, we see these people every day and we have to make decisions on hormones and things. That's a different way of working on these issues than I think our colleagues in the gender studies department.
First of all, there are a lot of things that we do not know about our perception of what we are and how we envision ourselves. And there are lines of research that goes into understanding the communication within the brain, how we self-define ourselves. That's one part of defining or understanding. The other thing is we have a humanistic approach to understanding gender and that approach is sometimes in collision with a classic biological way of looking at reproduction. So the whole thing depends on what we want to communicate, and I don't think we're ready to have a statement that this is good for all in terms of what is how we should make things. It's very important that there are organizations, and we just have a colleague of mine who presented her PhD thesis on Friday, which is on it's called On Gender Dysphoria, and her name is Cecilia Bailey. And in there is sort of a review of all the terminologies in terms of how we should name things and what terms we should use in our communication. That's a long way to go if you go out in the medical community and talk about new ideas about presenting gender.
Just maybe to very briefly comment on that. But what I can get from your question is, yes, there's definitely a lack of research. I think we all agree on that. The horrible numbers that you were presenting in terms of like morbidities, suicidal tendencies, I think we actually, it's not so much like the theoretical framework. I think listening to the people, to the trans people themselves, and they will prove you every theory right or wrong. And they tell you kind of like the needs, like how we have to evolve. And that I think should be the focus of the research then, to see like how can we improve the living situation of trans people, focus on their on the healthcare needs holistically. And yes, the terms are evolving, so when you develop a new protocol, you want to make sure to serve the future generations to come. We're having many more new terms that we didn't know 5 years ago, and we want to make sure we would have a health protocol that is serving all of them. So you don't want to have like another like a box you have to jump in order to get the care you need. We have to think broader. We have to think out of these boxes. So there definitely, I think the evolving studies and also gender studies need to be an inspiration.
And Aedan, you had a small comment also?
Yeah, so it's very early days at the moment, but the University of Roehampton in London is in the process of writing protocols for a counselling psychology-based clinic, which is working purely with trans academics and trans practitioners, and also gender studies academics, so getting some real praxis involved and actually looking at trans embodiment rather than diagnosis, so feelings of being trans rather than labels assigned to that. So early days, but it's coming.
Okay, and we had a question down here.
Yeah, my name is Inge Tamrakon. I'm from Intersex Denmark. I have a question regarding Peggy, you spoke about a number of intersex people seeking treatment in the transgender department. I know in Denmark, if you are assigned a male gender at birth and you feel like a female when you grow up, you are in many times referred to transgender treatment here. And I would like to know, how does transgender treatment differ from intersex treatment in the department you spoke about?
Well, it's basically the same, but the requirements are a little bit different. I mean, if a child has grown up with an intersex condition of some sort, already from the beginning showing gender dysphoria, it's much more easily accepted that very early in the development, medical interventions can be done. Whereas if a child only develops it late in childhood or even only in adolescence, it takes a little bit longer to be sure that this is the way you want to go. That's one example. So you have more individualized decisions on intersex kids. No, we never counted that, how many there are. It's occasionally they are there, and sometimes they are coming from pediatrics because they are born and they are known as an intersex kid from birth on. They grow up, and then some of the pediatricians ask us, do we want to counsel that child for a while? And then if it looks like it's going in this direction, they are sort of joining the child and adolescent gender team.
Okay, and now we have back row, and then we then you, and then here. Yeah.
Thank you. I want to return to the first question actually, because I think that can be expanded on. I think that's a very interesting question. You all mentioned multidisciplinarity, And when you mentioned multidisciplinarity, you focused on psychology and then some medical fields. And maybe just to motivate the first question a bit more, I think that could maybe be approached wider than just focusing on psychology and then some medical professions, because it poses a fundamental question, right? What is multidisciplinarity? And you have this common saying, when you have a hammer, everything looks like a nail. And I would say that when you look from things from a medical perspective, that's the hammer, and everything looks like a nail. So how do you, or do you give some thoughts to how can you incorporate more more disciplines into your production of knowledge when it comes to gender? And this is not a novelty. If you look at the Hvidovre hospital in Denmark, they have a psychiatric department where they include philosophers, people from literature, and so on, because they ask themselves the fundamental question: what is reality? What does it mean to be a person? What is identity? Couldn't you do that in this profession when it comes to gender as well? Which, I mean, no matter how you look at gender, no matter how your definition is, you cannot exclude some sort of social dimension. Thank you.
Okay, Peggy and Stefan.
Well, I absolutely agree with you. This involves so many different aspects of fundamentals in life. And when I say multidisciplinary, well, it's fairly square from coming from me as a somatic medicine endocrinologist, very square way of thinking, basically. But to sort of have different specialties grind against each other. So just to take the step to merge somatic care with psychiatric care, that was a journey, I can tell you. And to understand our different way of approaching problems. Then we have behavior scientists, which are very important in the multidisciplinary team. And we have those who look at limitations in terms of what can we do with our scissors and needs as surgeons. The other aspect, the literature aspect, the philosophical aspect, well, that's something that is a privilege if we can have some person come into us and discuss those issues, because I think they're very important. We so easily look up ourselves in a certain train of thoughts, and that we need someone to, follow this, and suddenly you start to understand other aspects of something that's going to be managed.
But isn't it also about how you organize yourselves? Not just how you think, but also how you organize yourselves to kind of endorse that way of thinking.
Well, in our clinic, maybe that's a pretty recent development. Is we have students of these departments coming to our clinic and looking around, seeing how we are talking about things. And because we have contact with their supervisors, we are much more closer to the people from all these other departments than we used to be. I don't know where it will end, but I think that would be one approach to involve other disciplines more than we did so far.
Okay, small comment here.
Yeah, small comment from my side as well. I think the key is education. It's not so much to have like more multidisciplinary teams as mandatory, because then that means you're creating more bottlenecks. But we should actually think, where can we dissect the different care aspects so that the GP can administer the hormones and the post-surgical care. Where can a mental health professional who is not trained necessarily on trans issues or specialized on it still see a trans patient? So we kind of like share where people can go to in the health system. I do totally agree that there's a lot of mutual beneficial exchange that can happen when people from different disciplines talk to each other. TGEU is a proud founding member of EPATH, the European Professional Association for Trans Healthcare. It's just now, next week, meeting in Belgrade for the second time, where you have like healthcare professionals from all kinds of professions exchanging and talking about their research and how they come together. And we have seen very good results in countries where there are more formal or less formal networks of care providers who are exchanging themselves, from psychologists to endocrinologists to surgeons in one network, to see kind of like how can we improve care and how can we work together, without having these kind of like, again, a little bottleneck like clinics, so like where like, there's this forced interlinkage, because it's not for every case really, or for every person necessary.
All right, and then we have third row here.
Can you hear me? Yeah. Hello, my name is Nicola. I'm a psychologist and I'm a mother to a transgender child. I'm the chairman of a Danish union called FSTB. It's a union established by parents to transgender children with the purpose to support them and give parents the possibility to be into a network. This is a question for you, Peggy. You were talking about you are having some ethically and moral discussions in your team. And I would like to ask you if you find it ethically alright to put an age limit of 12 for puberty blockers, even though we know that some children in a stage 4 or 5 at that age.
Well, that's exactly why we are now taking more individualized decisions. We started with these age limits because there were legal aspects on it. As I told you, that when we started, it was very negatively evaluated by our environment. So we had to be sort of clear and have strict regulations. Now we are many years further and have done a lot of studies further. We can much more easily say, well, we should not do that, particularly not for the girls assigned, of the kids assigned as girls, because they are earlier in puberty than boys. So what we do now is we look more closely to the tender stage and see whether the child is ready, and then make the decision to let them start.
And then here on the fourth row.
Well, actually, I kind of regret that there's a person missing in the panel up there, because I should have liked to have heard now the reflections from the Danish Health Authorities on the speeches that we've heard, and whether perhaps they are ready to pick up the baton as extended from, for example, Transgender Europe, to help write a really future-based Danish protocol. I completely agree with you, Richard, that we have a unique opportunity now to write something that reaches well into the future, and that can go and become a forefront for treatment of transgender people. But as you are now here, professors, I will extend then the question to you and say, which reflections do you have on, for example, the proposition of releasing capacity in the system by not necessarily having obligatory multidisciplinary teams, and perhaps moving capacity from this obligatory psychiatric evaluation to other fields that are more to the benefit of the people, as we hear it here? Why do we have to maintain a psychiatric evaluation as part of treatment, or as a prerogative for treatment?
Well, first, I must say, psychiatry is not so much involved in our clinic. It's usually the psychologists who are doing the work. And for a long time, particularly because of the waiting list, we have tried to spread the work throughout the country. But repeatedly, we encountered problems because people were just not interested in doing the kind of work. Only very recently, there are now 2 centers, well, centers of groups of psychologists, who say that they want to do some of this work together with endocrinologists who are also not part of our multidisciplinary team. But that's a very recent development. And I was struck by the fact that there was so little interest from professionals to do this.
Well, actually, I don't understand why this group of people with this complicated situation should be withheld sort of specialized people who have a deep understanding in, for instance, medical care, which is not an easy task. It's not a sort of a simple protocol you can set out and say, use this as you can do on the net. I think that would be probably giving sort of a negative help to people. I'm not sure that that will release any type of resources. I think if we work in a very efficient way, because we have a lot of experience and a lot of specialized knowledge, which is not very well spread, we can do things much quicker with less resources. And of course, a lot of the things can be followed up in primary care, so used in that part. But at some instances, I don't think it would be unresponsible to say, come on, you can have this treatment, you should take care of that in the primary care. Because the primary care is suffocating with the burden they have today. That wouldn't ease up any resources.
Was that satisfactory?
No.
Well,
No.
You look like
I
it.
still, I don't know what, I still don't understand if let me take this as an example, it's easier. If I came to you asking for hormone treatment, why should a multidisciplinary team counting psychiatrists and surgeons and so on have any say in that?
Nothing.
I should go to an endocrinologist.
Absolutely.
I don't need a multidisciplinary team to decide over all that.
You don't have a multidisciplinary team to force resources on people. The multidisciplinary team is access to possibilities, but you don't need to use all the possibilities. I don't need to use a psychiatrist if we don't have a psychiatric problem. They don't need to see me if they don't have memory. So that is just that we have on the same place, under the same roof, all, not all, but a large part of the sort of people who are devoted to this type of care within a single reach, instead of having people spread out around. You have to write letters, you have to, this is sort of making it very efficient, and you should not overuse them. You don't have to use all the resources for things that is easily taken care of by a single specialist or a single professional. I don't understand that way of thinking at all.
I hope the Danish authorities are listening very closely.
Are you completely against having specialized centers, or are you saying that
As long
that
as
should be there as well?
As long as they create bottlenecks and monopoly on treatment, yes.
Okay, we have, I think it's going to be the last question, but I know that Mr. Søren Brostrøm at the end of the day will pick up some take-home messages for you and perhaps for himself. He might think. Now it's you.
Hi, my name is Stefan. I'm from Institutet Denmark, and I'd like to ask a question to Stefan. Taking into consideration that transgender treatment in Sweden is based on or required upon the WHO F64 diagnosis, how are you considering intersex people who doesn't agree with the gender they were assigned at birth, based on the fact that intersex people can't be trans according to that diagnosis? Was that?
If you have a gender identity issue that is bothering you and cause concern and suffering, well, that should be addressed according to what your problem is. And the diagnostic system is something that we have sort of been given, and that is around that the whole, at least in Sweden, the whole medical care system is built. So if you want to do something, you have to wiggle around this diagnosis system. Sometimes there are completely idiotic diagnoses, and this should be a battle. And then there's a room for sort of negotiating that. And there are things that are not yet invented that we see in reality, that is not in the Bible of diagnosis, that has also to be praised. So you have to have a lot of pragmatism, and when you do changes, you should not be super happy because we got rid of that diagnosis and left a vacuum for a lot of people who will not be served. That's not a good idea, according biology.
And Richard, you have
Maybe just like, if you allow me like a last word to go to like the last two questions in terms of, we heard now like all these complicated people and the responsibility of like dropping that on primary care and a lot of talk about suffering. Let's look into the future and let's imagine like happy trans people. We want happy trans people and we want to think about providing care to prevent suffering. And I think like if we keep that in mind, like as our focus, like how we want to set up the new product, like, I think like that will help us to decide on a lot of difficult questions. We're not difficult.
No.
We're not.
No.
Okay, on that note, we will take a coffee break. You'll have to be back here at the